This is our last anatomy video, and this is on the elbow, forearm, wrist, hand, thumb, and fingers. So starting with the articulations, the elbow joint, what we traditionally think of as the elbow joint, is called the humero-ulnar joint. So this is only the humerus attaching at the ulna. Okay? Next to that, though, we have the humeroradial joint, which is the humerus and the radius. Now in flexion, the radius is in contact with the humerus, but in extension they are not in contact with each other at all. And the last joint that's in this area is the proximal radio-ulnar joint. It functions in combination with the distal radio-ulnar joint to give us that pronation and supination. So proximal radio-ulnar is simply the ulna and the radius just below the elbow. Now I'm going to cover ligaments just while we're here. The capsule is relatively thin at the elbow, but is reinforced by musculature and these strong ligaments. The elbow is the strongest joint in the body just in its bony structure. So it's very difficult to dislocate and very difficult to get back to 100% if you do dislocate it. You can see from the pictures here how extensive the ligament support is. We have the medial collateral ligament on the medial side, the ulnar collateral ligament on the lateral side. You can see them here, medial and lateral. Now the other ligament that's of importance here is this one. This is the annular ligament, and it connects the radius to the ulna. It is actually the only point that you have connection there. So it's a very important ligament, and it can be damaged, or you can dislocate the radial head out of that circular ligament. We have the forearm bones. The ulna is longer at the elbow. The radius is longer at the wrist, and then there is the interosseous membrane between. As we get into the wrist, we have the radiocarpal joint, which is the main joint of the wrist. So this is the radius meeting with the carpal bones. This is a condyloid joint, so you're going to get flexion and extension, as well as ab and adduction. Okay, it's going to get its strength just from the tendons of the forearm muscles. As you can see, it is not very strong in bony structure, and it doesn't have a lot of ligament support. In the carpal bones themselves, they're the joints of all of them meeting each other. And these are arthroidal joints, so that you have gliding movements. And each of these is stabilized by ligaments on the anterior and posterior surface, as well as with each other. So any of those ligaments can be sprained with certain mechanism injuries. You also are then going to have the joint between the metacarpals and the carpals. Okay? And these joints are also those gliding movements where you will get some flexion and extension and ab and adduction. The main joints you're going to see are the metacarpal phalangeal joints here, and these are condyloid joints. You get flexion and extension, ab and adduction, and in the thumb, which is a saddle joint, you also get rotation. The last joints we have are just like in the toes. We have the interphalangeal joints, and these are hinge joints. They give us flexion and extension. Now, every single one of these joints in the wrist and the hand have ligaments on the anterior and posterior surface, as well as lateral and collateral ligaments. And any of those can be sprained, especially when you jam fingers like with basketballs. Moving on to the blood and nerve supply, I mentioned in the shoulder that the majority of the blood and nerve supply comes down the anterior medial arm. We have the brachial artery that comes down and then splits into radial and ulnar arteries. In the nerves, we have the median nerve, which runs down the middle of the anterior arm. We have the ulnar nerve, which runs down the median side of the arm, and the radial nerve, which runs down the posterior. When we get into the hand, you can see how extensive the blood supply and nerve supply is here, and this is what gives us our increased sensation in the hand. As we move into muscles, there are a few that cross the elbow joint from the upper arm. We have the bicep and the brachialis, as well as the brachioradialis. And then on the back side, we have the triceps. There's the supinator and pronator teres, which obviously creates supination and pronation. And beyond that, we're going to limit our discussion of the muscles of the forearm to forearm flexors, which are found on the anterior side, so when the palm is facing forward, and the extensors, which are on the back side or the posterior side of the arm. Okay, we're not going to identify the individual muscles. We're simply going to call them flexors and extensors. And in the hand, like we had in the foot, we have two sets of muscles. We have the muscles, the intrinsic muscles on the palm side, which are pad muscles. They adduct or bring the fingers together. And on the dorsal side, the dorsal interossei muscles are the dab muscles. They abduct. So the dorsal abducts, it takes the fingers apart, and the palmar adducts. The one other thing we have in the hand is the thenar and the hypothenar eminences. Thenar is on the thumb side. It's three muscles that control just the thumb. The hypothenar is on the pinky side, and again, three muscles that control only the pinky. Okay? Generally, the muscles are creating opposition, which is where the thumb can touch all of the other fingers. Okay? So movements. At the elbow, we have only flexion and extension. At the forearm, we have only pronation and supination. At the wrist, we have flexion, extension, and ulnar and radial deviation. Now, ulnar and radial deviation are your ab and adduction. Ulnar moves to the ulnar side, and radial moves to the radial side. At the metacarpophalangeal joints, we have flexion, extension, ab and adduction. At the fingers, we have flexion and extension, and then the thumb, we have opposition. And we'll go through all of those in the lab. The last thing I'm going to talk about is the carrying angle. When you stand up and extend your arms to the side, you'll notice that your elbows are closer to your body than your wrists. This is called the carrying angle. In females, it is generally 10 to 15 degrees. And in males, it's a little smaller at 5 to 10 degrees. And it is designed so that when you are standing or carrying things, they don't run into the legs and you don't have to abduct the arms at the shoulder. So we will look for that in the lab with each other. Some people's are a little bit wider, some are a little bit narrower, but generally the norm falls between that 5 and 15 degrees.